Good evening. Welcome to ASTRO's Diversity, Equity, Inclusion in Radiation Oncology Social Education Series. My name is Dr. Chike Madu, and I will be your co-host for today's session on addressing structural racism and radiation oncology. DEIinRO is a new social education series that focuses on diversity, equity, and belonging in radiation oncology, brought to you by the newly formed ASTRO ex officio Council on Health Equity, Diversity, and Inclusion, CHEDI, and the Division of Education. This series focuses on conversations with our members, residents, students, and patient community, as well as leaders in various specialties and industries on several topics related to DEI and belonging. The DEI in Radiation Oncology program is designed for us to share our experiences, our research, ask questions, and openly discuss.
Oh, I think we lost Dr. Madu. So we'll give her a minute to see if she can log back in. But in the meantime, we were going to start with some introductions, so we can go ahead and do that. My name is Kirtland DeVille. I'm a radiation oncologist, associate professor at Johns Hopkins School of Medicine, and medical director of the Hopkins Proton Therapy Center. I'm also on the ASTRO board of directors as the ex officio board member for the Health Equity, Diversity, Inclusion Council, and one of the co-moderators today with my colleague, Dr. Madu. I wanted to go around and give the panelists the opportunity to introduce themselves. We have a wonderful, esteemed panel today. So we'll do that, but actually I see Dr. Madu is back on. Did you want to introduce yourself first, Dr. Madu, and then we'll go, I'll pass it off to the first panelist.
No problem, sorry about the technical difficulties. As I mentioned earlier, my name is Dr. Chike Madu. I am a radiation oncologist and assistant professor at the Zucker School of Medicine at Hofstra Northwell, and I chair the Commission on Cancer at my home institution at SIUH. I also co-lead the advocacy working group of CHEDI. I'm delighted to be here, and I'll pass it on to you, Dr. DeVille.
Okay, wonderful. Let's start with Dr. Jacobson, please.
Hello, I'm really happy to be in this program. My name is Geraldine Jacobson. I'm the chair of radiation oncology at West Virginia University. I'm also the current president of ASTRO. My clinical research interests include image-guided radiation treatment for breast and gynecologic cancer and reducing the acute and long-term toxicities of treatment. But as a member of the board of directors of ASTRO for the last several years, and as the current president of ASTRO, I'm interested in any topic or issue that relates to the field of radiation oncology, our membership, or the patients we treat. And so with that in mind, this topic, increasing diversity, equity, inclusion within ASTRO is a really important topic for all of us and for me. Thanks.
Wonderful. Thanks, Dr. Jacobson. Dr. Kavanaugh, will go to you next.
Hi, thanks also for the chance to participate. I'm Brian Kavanaugh. I'm a radiation oncologist at the University of Colorado. I'm here, I suppose, to give some historical perspective and some of ASTRO's activities in this realm, since I guess I'm an ASTRO lifer. I suppose I've been on ASTRO committees for beyond 25 years or so. 2011, I was elected to the board, first as the rep of the Health Policy Council, and then in 2015 as the person on the presidential track. So I'll try to share some historical perspective and what's gone on up to this point. But I'm really glad we're talking about this topic. It's an important thing, and this series is a great one, and I've seen a bunch of them so far, and I hope we can continue the good dialogue in this one.
Great. Thanks, Dr. Kavanaugh. Dr. Miller, we'll go to you next.
Hi, my name is Robert Miller. I'm currently Director of Radiation Oncology at the University of Tennessee in Knoxville, where we're building an academic program focused on disparities in care for Appalachian cancer patients. Previously, I practiced at the Mayo Clinic for 25 years and where I remain an emeritus professor. I'm here today representing advances in radiation oncology as editor-in-chief. Thanks.
Wonderful. Thanks, Dr. Miller. Dr. Simon, we'll go to you next, and welcome.
Thank you all for having me. I am at Northwestern Feinberg School of Medicine in Chicago. I'm an OBGYN, so I'm not a radiation oncologist, but I lead the Center for Health Equity Transformation, and I'm chair of the Health Equity Committee for the ECOG Akron and NCI and core research base.
Great. Okay, thank you, Dr. Simon. Dr. Chapman, we'll go to you next.
Hi, I'm Christina Chapman. I'm an adjunct assistant professor at the University of Michigan. I specialize in lung and head and neck cancers, and I'm a health equity researcher. I'm a member of ASTRO's Committee on Health Equity, Diversity, and Inclusion, and I'm vice chair for the scientific track for CHEDI. And I'm excited to be here. Thank you.
All right, last but certainly not least, Dr. Ray Mayo-Vega.
Hi, I'm Ray Mayo-Vega. I'm an assistant professor of radiation oncology at the University of Florida, specifically at the Proton Therapy Institute. I lead the workforce working group for CHEDI. I have the pleasure of treating children and women with breast cancer, and also lead our lymphoma radiotherapy program. Thank you for having me.
Okay, great. Well, as you can see, we have a wonderful panel assembled to address this issue of structural racism in radiation oncology, and hopefully to have a good conversation, kind of thought-provoking, and help us move along the path forward as best we can. I think it's always great to open up and start with some definitions to make sure we're all talking about the same thing and on the same page. So I would like to go to Dr. Chapman. If you could help us set the stage here, speak about what is structural racism and perhaps also why this has come to the forefront now.
Yeah, thank you. So I'm going to start with a definition that was published in a Lancet article from 2017, of which Mary Bassett was senior author, just so that we're all on the same page. So structural racism refers to the totality of ways in which societies foster racial discrimination through mutually reinforcing systems of housing, education, employment, earnings, benefits, credit, media, healthcare, and criminal justice. these patterns and practices in turn reinforce discriminatory beliefs, values, and distribution of resources. So that was a pretty long definition, and it actually could be longer because structural racism really is everywhere and embedded in part of everything that we do and has intersections with everything that we do. I want to emphasize a few components of that definition. So first, Kamara Phyllis-Jones, who's a leader in public health and anti-racism, published a seminal article now 20 years ago where she describes 3 types of racism. So she describes institutionalized racism, interpersonal racism, and internalized racism. And so structural racism can be thought of as kind of a broader categorization of what she denoted as institutionalized racism. And so in this definition from this Lancet article, if you recall, you'll notice that I said reinforce discriminatory beliefs. So when we think about, structural racism and all of the procedures, processes, and institutions, it's important to understand that they intersect with those 2 other types of racism, right? So those discriminatory beliefs can manifest as the interpersonal type of racism that Dr. Jones speaks about, and they can also manifest as the internalized type of racism. And all 3 of those, of course, can have broad and deep impacts on health, and then all of the other upstream factors that impact health. Another thing that I want to emphasize from the definition is that, again, the definition was the totality of ways in which societies foster, right? Societies foster. So I want to make a distinction between that and, right, something like a hurricane or a rainstorm or some other sort of natural disaster over which we have no control, right? Societies foster racism. They created racism, right? People made a deliberate decision, right, to put my ancestors on slave ships many hundreds of years ago, and then to continue to write into law policies that are explicitly, racist. And many of those policies have been removed, right? But there are also many contemporary policies, norms, and practices that don't appear to be racist on their face and appear to be race neutral, but actually perpetuate racism. So I'll stop there.
Thanks, Dr. Chapman. Definitely that context and perspective is, I think, useful for us to sort of set the scene here. But I wonder, how can we link this, for our audience and for folks listening? How does this show up in medicine, and sort of draw in some of the panelists? Dr. Simon.
So if I can just take the definitions that Dr. Chapman spot on gave, just one step further to help us apply it to everything in healthcare delivery, workforce, everything like that. So if you were to, as Congressman John Lewis used to say, you got to look under the hood of the car and look at the structure. So if we're looking at every single structure, policy, practice, search committee, opportunity given versus not, we got to think about which way that structure is bent. And if the structure is bent towards advantaging some people or a population or a person and actively disadvantaging another person or population, then we got to seek to either blow it up and start over again or unbend that structure, right, to make it equity for everyone, not equal. Equity means that you acknowledge that everybody needs some different type of unique personalized lift or support to get to a particular outcome, whether it's a promotion, whether it's a healthcare outcome, a cancer survivorship, whatever it is. That's equity. Equal would mean you give everybody the same lift, and then that still perpetuates the disadvantage of one population over another.
Dr. Mayo-Vega, you had a comment?
Yeah, I think to echo what Doctors Chapman and Simon have said, I think the way I view racism when we're talking about structural is to almost separate intent versus impact. So I'm from Birmingham, Alabama, and that has a definite history of violent racism. You know, you think Bull Connor, you think the 60s, you think the bombing of the church on September 15th. But at the same day, we can try to prioritize certain systems in order to, let's say, talk about the match. And at the end of the day, we can propagate a system that disadvantages certain types of people. In this case, we're talking about Black, Hispanic, and Indigenous. While the intent may be, you know, we're using an objective system such as US News and World Report, what actually happens is different. When we're talking about patient-facing, I think the most horrific article that came out last year was a letter in NEJM that demonstrated they took pulse oxes of patients, this was at the University of Michigan, and compared it to ABGs. And they saw that Black patients were 3 times more frequent to have occult hypoxemia, which, if you think about it, makes complete sense with what we understand how a pulse oximeter works. And it took a pandemic to actually understand that. And thinking about a healthcare system where we were trying to determine, you know, who gets to be intubated, who gets to be ventilated. When all of us work in practices where one of your 5 vital signs is that thing on your finger, that has implications that face our patients, not only in the sense of a pandemic and deciding who gets to get intubated, but then level of lung severity, someone's eligibility for a transplantation, the way we view chronic kidney disease, all probably had a good intent, but in the way that the people are actually affected by it can be harmful based on what group you're a part of.
Well, it's great that you bring that up, Dr. Mayo-Vega. I think, and perhaps one of our panelists can comment that there is certainly a re-examination of our kind of race-based nomograms and various, you know, tools that have developed over time that, you know, seem to have ignored, you know, the issues of racism and sort of assuming race as biology and not race as a social kind of cultural geopolitical construct. Anything more to add to that, one of the panel? Please, Dr. Chapman.
Yeah, I want to add, and I'm happy that this issue was raised. So there's some like confusion, or perhaps actually it's not confusion. I think some of it is deliberate, right? That when we call to end like inappropriate use of race and racism, there are these calls to stop measurement of race, right? And we know that if there's a problem, in order to fix that problem, we must not only measure it, but sometimes, right, race and utilizing race is going to have to be part of that solution. And this is really, these tactics are pretty old, right? They're pretty common in the context of like college admissions, where people say we should be race neutral and it's racist to consider race, right? But how are you going to undo racism if you don't use race, right? Racism is not the same thing as socioeconomic disadvantage, right? There is significant overlap because of the way that racism operates, right? But even physicians, right? Even someone who's a radiation oncologist who gets paid a radiation oncology salary, who's Black or Latinx or Native American, will experience racism. And so this topic is, I'm pretty passionate about this because I just actually had a paper that was published 2 weeks ago in Annals of Internal Medicine, and the editorial in response to my article was entitled, you know, Time to End Race-Based Medicine, when I published a paper with an actual solution on how to reduce racial disparities for Black women and breast cancer. And so the person who wrote the editorial, who was a white male professor from Harvard who's retired from clinical practice, right, is sort of taking this concept of us wanting to eliminate racism and taking my work, which is really, right, one of few solutions, because we've had decades of describing race and now saying, oh, we should just stop talking about it, right? So we have to distinguish, we have to make a distinction between things like, you know, using race in GFR where it doesn't belong, where it causes further racial disadvantage, and using race as a tool of measurement to, you know, identify those who should be subject to targeted solutions, given that they've been affected by racism.
And since we're on the topic of research, perhaps Dr. Miller, I can call on you here. And in your role, I know that I should disclose also I'm the GU editor on Advances. And so I know some of the behind the scenes, but you've been very intentional in your efforts at increasing diversity, and in my mind, at least, addressing this issue of structural racism. I wonder if you could talk a little bit about that.
Oh, thanks, Dr. DeVille. What I've got to say, I think, is pretty brief. I've got a couple, I think, teaching points, and they're probably, points we're all familiar with, but bear repeating. When we started Advances, we tried to really take a deliberate attempt to propagate or publish research in disparities, become a platform for that, to look at these problems and disseminate manuscripts and solutions. Last summer, in July, obviously some big issues happened in this country. And as editor, as I watched them, even before the protests had died down, people started talking about moving on. And as editor, I tried to think, well, should I do something? And, teaching point number one is when you're in a position like that, the really safe thing is to just not do anything. And it's an easy thing, and absence of action doesn't put you at risk. And so I think, the first thing I'd like to share is that that's the kind of thing that Chetty needs to, hopefully address and get people in our profession to realize you need to take action. Inaction isn't going to help us, get anywhere. It's going to hinder us. Second thing I thought, looking at the aftermath of the protests, or again, even as they were still going on, people started talking about, we need to move on. We put this behind us. And I thought that there needs to be a real conversation in our profession about this. That how can we come back to this point, and at least as an editor publishing manuscripts, can I provoke a serious conversation and get people to think, what are the problems associated with racism as it impacts our profession? So Dr. DeVille and I had some conversations, and then Dr. Karen Winkfield, who I'm sure many of you out in the audience and everyone on the panel knows, I contacted her and I asked her to write a manuscript. And she asked me, well, what are my limits? And I said, well, there really aren't any limits. What I want you to do is write about what's important to you. And so she recruited a number of people. And then she asked, when did you want it? And this was Friday night. And I said, I kind of like it by Monday because of the immediacy of the topic. And so you'll see a reference to that on the website, generate a lot of attention and discussion. It's one of the few manuscripts in radiation oncology that is broadly cross disciplines, and people that have read it and shared it, it really spread widely in academic medicine. And great work by Dr. Winkfield and Dr. Penix and Dr. DeVille. And so the second point is, many of you will be faced with a choice, and it's important to do the right thing. Thanks.
Thank you, Dr. Miller. And I'll shout out Dr. Chapin as well, who was the lead author on that paper. And we it was a not to toot our own horns, because that certainly was not the goal, but we worked through the weekend probably as feverishly as we had ever worked to pull that together. So encourage the audience, if they have not read that Why Racial Justice Matters in Radiation Oncology reference, to certainly read it. There's tons of information there to really sort of set the tone, and probably will fill in a lot of pieces that we may not get to talk about today in this conversation. But I wonder if I could loop in some of the ASTRO leadership at this point, since we're talking about what leaders can do and how we can help our field and specialty move this issue forward. Dr. Kavanaugh, you mentioned that you were involved, can bring the historical perspective of how DEI has moved forward with ASTRO. So, thank you.
Yeah, thanks. I tried to do a little homework on that. And I think one thing I said during our prep session was that I was going to read anything I might have written so that I'm not going to contradict my own self in that. And so I'm just going to start off with one sentence. I won't bore you with anything much I've written. I'll start off with one sentence because this is sort of a way of disclosure. And it's the first sentence of a piece I wrote in Astro News. It was called The Necessary Reflection on Diversity and Inclusion. It was a couple years ago. And the first sentence is, it would be disingenuous for me to pretend that I have firsthand understanding of the frustration and pain that can be inflicted by racial, ethnic, and gender biases, period, full stop. That's my disclosure. I want to be totally clear that I'm speaking as someone who has not had the firsthand experiences that others and many people have had. I try to be sympathetic as I can to it, but I have to openly admit that it's secondhand observations and such as that. So with that said, the only other thing I want to say before I get back into a little bit of background is that, we were talking about a very serious problem, and it's a problem that is like changing the course of an ocean liner, right? It's going to take incremental steps and bits and pieces of progress. But every once in a while, I just want to say that there is some good news. I just want to mention one item of good news that I'm happy about personally, and it is that Dr. Jerry Jaboyne has been appointed the chair at Oklahoma University. And if those of you who know Dr. Jaboyne, he is a good guy. He's a good man. He's a good radiation oncologist. He's a good teacher, and he's a good person. I've had the privilege of knowing him for some length of time, and I'm super happy for that. And I just wanted to at least put in one item of good news, because that's maybe how this is going to have to evolve and improve. It's step by step, spot by spot, position by position, individual by individual. And so it's just nice to see an incremental, small but distinct step that matters for an individual person. So, I mean, what I think we had talked about at the prep session was maybe it's useful just to take us from where it all started up to the present time as far as what the organization ASTRO has and has not done to this point. So I'm going to try to be as efficient as I can in summarizing the 20 or so years of history of that organization and its interaction with diversity and inclusion issues. It was about 20 years ago that the first ASTRO NCI symposium was held on the topic of bringing diversity to radiation oncology. A few years later, the organization formed a workforce diversity committee. There was also a committee for healthcare access and training not so long after that. I want to say that this takes us up to something around 2013. And that was a very nice paper by Drs. Chapman and DeVille that was published in the Red Journal around that time that quantified the landscape, if you will, of just what did radiation oncology look like at the time. And I think, as you recall, it was a disappointing showing that maybe only about 7 or 8% of trainees and rad-onc faculty were from underrepresented minorities. In particular, even about less than half of that were Black individuals. So a lot of work to do and a lot of progress, opportunities for improvement, let's just say. So that, I think, was beginning to help grow the consciousness of this as a challenge and an important problem. In 2016, the Committee on Health Equity, Diversion, and Inclusion, CHEDI, was formed. Then it's always been the thing, the cycle that around every 5 years or so, the organization renews and revisits and re-updates its own strategic plan. I was on in 2011 when I saw this first happen under Dr. Gunderson, and it was process that was a little bit clumsy and chunky. Around about 2016, when David Beyer was trying to start to reinvigorate this process, we realized that not only did we need to update it, we need to just reformat it, because it was this clumsy, odd-looking document. So it was reformatted, and it included, among other things, a statement of core values. And I think it was notable that among the core values, there was excellence in patient care, improved outcomes, innovation, integrity, and importantly, diversity and inclusion. So here you had the first introduction of language that stated openly that the organization has a vested interest and considers it an important part of its being and its consciousness. Still a lot of improvement to be had there. Now, it was also around 2017. It's taken stuff now. ASCO, I would say, actually took it even a step further, because they've tried to put out a little bit of a roadmap on how to improve diversity in oncology. And our own favorite, Dr. Karen Wingfield, was actually the lead author on that. You may recall this publication coming out around 2017 or so. It had a few suggestions of specific steps, one of which was to institute some training and mentorship programs and a few other things like that. So ASTRO listened, I think, to that piece of information and began to do a couple of steps. It was actually 2018 that the organization launched so at the time it was called a Pipeline Protege Program. Now it's called a Leadership Pipeline Program. I'm tripping all over that. Dr. DeVille himself being of the first cohort, the first graduating class. And you can maybe comment on the extent to which you think that's a good step in the right direction. How can that program be improved? And that you've had a few years of perspective on that. That would be great to hear. And so, that takes us up to around 2019. And so I then left the board 2019. I feel guilty because, boy, the next year, as soon as I left, there was some serious stuff going on. There was this virus going around and a few other major national events. But I'll stop talking right there, because I'll let Dr. Jacobson take up the extremely modern history of anything, what the organization has done. So please, Dr. Jacobson, if you can pick up the story from there.
So before I sort of move in, I didn't know, Dr. DeVille, if you wanted to ask Dr. Kavanaugh anything else or elaborate on any of the things that he brought up.
Oh, no, please go ahead, Dr. Jacobson.
Okay, sure. So I think I'll start out with the core values because it certainly has been brought to our attention as ASTRO leaders that we included diversity and inclusion as a core value, but we didn't have specific goals and we didn't have strategies to move that forward. However, in rereading that document, I saw that under the area elevating radiation oncology, that one of the items was that we realized that our membership, our doctors should represent the patients we treat. So we had that thread of an idea that we're going to have a better society and be better radiation oncologists if some of us are all of us represent the patients we treat. And I think we know, people, so far the panelists haven't brought it up specifically, but Black Americans have worse health outcomes in many areas. It's not just cancer, but many other areas. And it's related to all of the things that were brought up by Dr. Chapman as what structural racism means. So going forward, as far as ASTRO values and ASTRO actions, we're going to have the opportunity to create a new strategic plan in January of 2022. So hopefully we will have our HEDI council in place to give input into this plan. And then I'd like to backtrack a little because one of the questions that I see that I was asked to address was ASTRO's role in dismantling structural racism. So if we start with Dr. Chapman's wider description of structural racism, I feel that I'm but a mote of dust in a universe. So I'd like to sort of have a more confined description of that. So another description of structural racism is longstanding institutional traditions and policies that result in racial inequity. And I think if we're talking about organization ASTRO, that is a starting point. And another version of that would be how we did things, how we do things, how they contribute to racial inequity. And so that gives us a starting point for change. So what we need to do in ASTRO is we need to change how we do things. And I would say that I'm seeing some of those changes over the last year. And Dr. DeVille, I think you've been witness to some of that and actually a promoter of that. So we're aware of the events of the summer of 2020, and I applaud Dr. Miller really using that as an opportunity to say, hey, radiation oncology, we have a problem and we're a part of the problem and we've got to do something here. And so we took that to heart. CHEDI, the Committee for Health, Equity, Diversity, and Inclusion, created really a pathway to move health, equity, diversity, and inclusion forward in ASTRO, and they made several recommendations. So I think I'll start with one of the most important. And for several years, CHEDI has been a committee, and certainly they have contributed to a lot of programs for Black and underrepresented minorities. However, they've been a committee and they're not at the leadership level. And so to make change in a society, you really have to make change throughout the society. It has to be at the leadership level, within the membership, and in recruiting and training new members in the society. So at the leadership level, it was suggested that we have a HEDI council, and we have moved forward in that. I think for about a year, we've had CHEDI members ex officio at our board meetings, and that's Dr. DeVille and Dr. Winkler. And in the last year, we looked for a path forward to create the council. We are doing that. A message went out to our membership on October 13th, saying that we are going to have a vote to change the bylaws to create a HEDI council. And that vote is going to be sent out on November 17th. So one of the other things that we were asked to do during this discussion is to discuss any action item. So I have an action item. So on November 17th, the membership or ASTRO are going to have the opportunity to vote to form the new HEDI council. That vote is going to be open for a month. please vote. Tell everyone you know to vote. If you're on social media, put out that message. So I think that's a really important action item. There have been other things we've done, but like I said, I think we have to change what we do and change how we operate, or nothing will be different. So I guess the first part of that is, hey, we have a problem. Let's look at the problem. What can we do? And I think we've started on that path. And then on a more, I guess, practical level, I can say my own experience for the last year. So I've just become the president of ASTRO, but prior to that, I was president-elect. And as president-elect, one of our roles is to be involved in selecting committee memberships. So if you want to change how ASTRO works, you have to start with the committees, because that is the vehicle. And so we have, I'm not sure which of the speakers said there's a difference between intended racism and sort of racism that sort of happens because of the way you do things. So the way we create and propagate committees in ASTRO, the intentions are good. It's that people who are engaged and people who demonstrate their competence move forward in ASTRO. So that's the good part. But the not so good part is it may be a smaller pool of people, and then the pool of people who go through the committee structure are those who are known by the people who are already in place. So it's a way to propagate what we've done before. So what was different, from my point of view, about last year is that at every step in choosing our committee members and who is going to stay on committees, we looked at it through the lens of diversity and inclusion. And that is a fundamental way to change ASTRO by what we're doing. Other suggestions that were made is, look, the leadership, this is our leadership now, they need training in what racism is. They need anti-racism training, and they need training on health equity and diversity. And so in October of 2020, we organized, and I think with input from several of the people on this panel, you could call it a workshop for our leadership with Dr. Miriam Jurgen Noisi on racism and how to move forward in our organization with health equity, diversity, and inclusion. And then if I think of other things that we're doing that are practical, I'm now in the process of looking at, I'm part of a team involved in creating next year's annual meeting, which is really the showcase for ASTRO and for our membership. And it's also how we present ourselves to the world. So we're planning to choose our speakers and our topics with the eye of equity, diversity, and inclusion. And hopefully we will have a heady council in place to help us with that.
Thank you so much, Dr. Jacobson, on that explanation of how ASTRO can work toward diversifying its workforce. We really appreciate it. Now, we also do know that structural racism impacts patient care by way of social issues such as access to care, insurance coverage, healthcare policy, transportation to and from radiation, financial toxicities related to coming for treatment or even getting enrolled in clinical trials. One of the goals of our advocacy group within CHETI for this year is to try to increase enrollment of minorities in clinical trials. We do know that there's several barriers that get in the way of enrolling minorities in clinical trials. And some of that I've mentioned already, but I think one of the things we need to think about is clinical trial design. We do know that a lot of clinical trials that are put out either by the big cooperative groups or even by individual institutions have eligibility criteria and ineligibility criteria that perhaps inadvertently exclude these minority patients that we talk about. So things like not having English as your first language, if you're talking about a quality of life study, or just even signing the consent if English is not your first language, you can't be enrolled in the trial. And things like certain comorbidities, you know, Dr. Chapman mentioned GFR. So if you have uncontrolled hypertension, uncontrolled diabetes, you automatically get disenfranchised in that. So is there a way you think that ASTRO can help influence the structure and clinical trial design so that we can start to take a look at how we design clinical trials, perhaps with a DEI lens? Is it possible for us to enroll patients with medical comorbidities and try to optimize those medical comorbidities while they're on that trial, as opposed to just completely eliminating them from those trials?
So that's a really important issue, and I hear what you're saying. Before I sort of recommend a pathway, I would say that, hearing what you're saying, it's not just how the trials are designed, it's how they're communicated to reach patients. And it may be an area where you need social marketing. Where are the patients getting information that you want to reach, and what message are they going to hear? As for a pathway forward, I think we've already heard about ways to do that. I think, we can ask Dr. Miller in advances to publish an article on the need for this. But I think your timing is perfect, because as I mentioned, we're talking about, looking at our strategic goals for ASTRO, but also all of the councils in ASTRO are now in the process of what are their goals, what do they want to focus on for the coming year. And I think if you share these concerns with our government relations committee, there's many things that are important to equity, that are things that we should be advocating for, that are really that would find their home in government relations when we talk to our representatives. So communicate, publish, think of specific goals, and share that with our government relations committee.
Thank you. We have been working with the Government Relations Committee on some of these issues, and we also have been working with the PR department of ASTRO. And one of the things we've been doing is talking to our patients, underrepresented patients who have perhaps participated in clinical trials, or who are willing to send out a message to the public about the importance of cancer screening. We can put up a video on the ASTRO website, but I think we need a louder voice to get the message out there.
Yes, and the things that we're talking about now are short-term solutions, but I think long-term solutions, and it's also part of the HEDI imperative, is that we want to recruit and train more radiation oncologists, because we know that Black patients are more likely to trust Black physicians. And so I think if our workforce changes, that's going to help us as well. But in the short term, it's advocacy and communication. And thank you for sharing that that's an important goal. I totally agree with that.
Thank you.
Dr. Simon, did you want to comment as well? I think, given your role with ECOG Akron and certainly thinking about these issues on that level, please feel free.
Yeah, I live, eat, breathe, sleep this topic. I've been doing it for many years now. The whole research pipeline is structural racism issues. The whole pipeline, from the funding source and how and who and how the request for proposals is designed. Think about, for example, the National Cancer Institute's Cancer Center Support Grants. Critical that the new structure of the CCSG grants, especially for the comprehensive status, now includes a brand new DEI component. It's a totally separate thing from the catchment area, community outreach engagement. And those two components, the community outreach and engagement, catchment work, and DEI, are critical to the score and critical to funding. So when you do that, you unbend that structure, you make it more equitable, or at least push it towards equity. It's unfortunate that we have to design funding to do that, but it's critical, a component. In terms of research, clinical trial, the whole base, it's more than just advocacy and patient outreach immediately. Yeah, that's important. But there's the clinical oncologists, right? The clinical radiation oncologists. You got to think of all the gatekeepers along the way. So making sure that ASTRO actually connects with the people who are the providers, the clinical care team members who are most likely to encounter or touch patients who are Black, who are Latino, who are of color. That's critical. Okay. Then also thinking about the proposal development pipeline right up front. Concept development has to have a health equity lens. Who are the people who bear the brunt of the disease right up front? With that concept review, somebody from the equity committee needs to review that, and that person's time who's reviewing it, or that group's time, should be reimbursed somehow, should be supported somehow, because this work is important work and it's hard work, and it's valuable. And then through the whole thing, when you actually submit the protocol, the review committee should have health equity experts on it to look at exclusion and inclusion criteria, just like what Dr. Madhu had mentioned, because blood pressure, for example, is one that does exclude some people from the trials. And it's not because of race. It's because the race as a biological variable. It's because the experience of race in this country puts you at a disadvantage for having a primary care medical home, puts you at a disadvantage for receiving consistent blood pressure control medication, et cetera. I could go on and on. And then the whole pipeline, the scientist workforce development pipeline, is critical to this. So having more investigators of color, making sure we are at the table and at all levels of leadership throughout the organization is critical, like was mentioned earlier. And then making sure that study protocol, when it's opened up, what are the sites that are opening it up? And how are they supported? Because the social and economic factors that influence whether a participant can participate, including transportation, out-of-pocket costs, financial toxicity, but also a site has those too. So if you have a community site and you have a high chance of maybe enrolling a lot of participants, there has to be funding embedded in that to support that structure for that trial to open, because sometimes sites can't open because of some of these social economic factors at the site level. So I'll stop there.
Thank you so much. Dr. Chapman?
Yeah, so an analogy was made to the navigation of a cruise ship. So I want everyone to just like take a second and think about that imagery and picture, a Carnival cruise ship with the water slide on top and navigating that and all the joys and happiness that comes with that. And then like stop and sort of abruptly shift your mind and actually think about if that were a slave ship, right? Because that's what a lot of us are on and have experienced. And so when I hear that analogy, it's always like a bit triggering, because there's something that needs to happen now and needs to happen today, and people are dying as a result. And so we have to figure out, especially, we are radiation oncologists. So if we want to think about the nuances of physics and how to navigate this cruise ship quickly, we actually have the expertise to do that. And so on this topic of clinical trials and getting, participation of excluded populations, we already know how to do that. And I always love to give the example of the VA larynx trial, because I trained and worked at the home of the VA larynx trial, which was the Ann Arbor VA. And the VA larynx trial started in 1985, which is the year I was born, right? So literally, we've known how to do this the entire time that I've been alive. The VA larynx trial only lost 7 patients to follow up out of 300. It was about 10% Black. There were definitely many rural patients on it, because the vast majority of my clinical practice at the Ann Arbor VA was rural patients from all across Michigan. And right, it wasn't just about doing, sort of diversity as this feel-good concept, right? That trial was published in the New England Journal. And it was a type of trial that probably many investigators in our field wish they could do, right? But one of the barriers to doing a trial like that, and the only reason it was able to be done in the VA system, it relates to structural racism, right? Because it's the way that the VA was funded and the lack of financial disincentive that allow that trial to be performed, whereas it would never have been, able to be so in the private sector. So like, we actually know how to do a lot of this. And the more we keep, purporting that it's some insurmountable problem that's just going to take forever. People just continue to die every day.
Thank you, Dr. Chapman. Dr. Kavanaugh, did you have a comment regarding trials?
Oh, well, when Dr. Simon was talking, it was so familiar, because I was just going to say and validate that we just got our CCSG scoring back, and the place we got dinged a little bit is that we need to do better in terms of exactly that enrollments metric. And we're now brainstorming as much as I can. So I appreciate hearing all the ideas that you guys are throwing out there to improve upon that. That's for sure.
Dr. Simon?
It's not just enrollment for DEI. That new component is actually who's the leadership, who's sitting at the leadership table of every level of that comprehensive cancer center. And it's not just participants in clinical trials that are a requirement. What's the budget? How does the funds flow? It's really looking under the hood of the car in every single DEI aspect of a comprehensive cancer center. It's pretty spot on, and I hope other RFAs and other organizations kind of align that way. Super critical.
Oh, go ahead, Dr. Mayowe. Thank you.
I think to go with what Dr. Simon had just mentioned and spoke about earlier with Dr. Jacobson is an idea of a top-down approach. So this is a bastardization of a JFK quote, but ask not what Astro can do for you, ask what you can do for Astro. And if Astro embodies this ideal of DEI, then ideally every member should feel empowered to notice if a situation is unequal, if the impact isn't okay. Because I think it's excellent that there's the possibility for Chetty to become a council. But if you add us up, we're still only people who identify as underrepresented minorities are still only 4% of the radiation oncology workforce, and that's a lot of work to put on our shoulders. But ideally, every single member feels empowered, whether you're on the Science Council, if you're on education, if you're on government relations, that you can be an outspoken supporter of diversity, equity, and inclusion. And so in those lenses, in those small groups, in every single committee, there's a way to incorporate it while Chetty can still exist and hopefully become heady and do further work in it. But every single member should feel empowered.
So I would like to make a comment on that, and that is everything is connected. So if there are people of color and Black people in leadership positions, then people who are in other areas of that organization are going to see them and think, I could do that. So I've had my own experience. I never thought of being a doctor, but when I was at a certain time of my life, I interacted with a woman physician and I thought, hey, I could do that. So until seeing somebody who looked like me, it didn't cross my mind. So having a diverse leadership group is going to help us have a more empowered group of physicians and radiation oncologists all throughout.
And I just want to highlight. I'm glad you mentioned that because there is a comment in the chat, and I don't know if Dr. Chapman or Simon, the comment you're going to make is sort of begins to address this, but. Someone had asked, but what about the very structures that are in place that are designed to exclude Black physicians from reaching higher ranking positions? And we could replace Black with, any of the, Latinx or indigenous groups as well that are excluded and underrepresented. Dr. Chapman or Simon, were you going to comment on that? Or if you have a different comment, please go ahead, Dr. Chapman.
Okay, yeah, I'll sort of, my comment can sort of apply to that. So I want to reflect on like two things, like what Dr. Jacobson just said about, women seeing women in leadership and Black people seeing Black people in leadership. And then also about like having more diversity in the field, and that helps clinical trial enrollment. So, all of those things are true. And it's difficult because I think we sometimes lose sight of what the root of the problem is. So, one of my favorite anti-racism leaders in medicine is Rhea Boyd. And so I want to refer everyone to, I always refer everyone to two of her references, one of which is in the Lancet 2019 called The Case for Desegregation. And that is where she uses the language of excluded as opposed to underrepresented. And I think that's a theme we need to keep in mind when we talk about this. But in reflecting on the topic of, needing this concept of like racial concordance and gender concordance, there's a more recent publication in the Health Affairs blog that she's on with a number of other investigators, called "The Standards for Publishing on Racial Health Inequities." And in there, they discuss this concept of racial concordance. And really, what we need to recognize, although it is certainly true that Black people are, inspired by other Black people and that Black patients feel comfortable, right? But the reason that is so is because of racism, right? So that doesn't need to be so. And it actually shouldn't be so, right? Because we should have a society where Black children, from the time they, come out of the womb, should be able to see themselves in anyone, regardless of whether they look like them or not, right? But we, again, have these deliberate policies and structures, some of them written, some of them unspoken. And those are what contribute to these issues in the pipeline. And those are what contribute to distrust, right? And it's very real. So what we need to do, like, of course, I agree, and have published on this topic of diversifying the workforce. But the whole reason we need to do this is because we have this problem of racism in medicine in broader society. And so I think that kind of, speaks to that question. And I saw that question come up in the chat, and I'm trying to, I was looking at the timestamp. I was trying to think about the timing, if it was right after Dr. Kavanaugh mentioned that Dr. Jabon had become chair. And, there were some nice positive adjectives that were conveyed about him. I mean, he's actually, right, is actually a force of nature. But I'm, super excited that he's in this position, but I think we can't be distracted by that, because we have to think about, right, the counterfactual as well. And I think if you asked many of us in the field, right, there's probably places we wanted to go or things we wanted to do, and, deliberate structures and policies and things that have been, put in place that need to be dismantled. So while I think we do need to, celebrate the people we have who hit those heights, there's a reason why we're celebrating those few people.
Thank you so much. And Dr. Simon, you had a comment?
Yeah, just to follow up with Dr. Chapin's spot on comments, we have to be intentional and strategic. And especially those of us who are in relatively higher positions of power. And we have got to actually leverage and call each other out with respect to department level, the Astro National Society level, and the research bases, and all of that needs to keep each other in check, because we're not going to train ourselves out of this. There is no amount of DEI anti-racism training. There is no amount of DEI committees, health equity committees that are going, or task forces that are going to get us out of this situation. It is on every single one of us, and especially the white counterparts, colleagues here, and the leaders, the high level leaders. It is on all of us. And it is super important that we take that point and carry it forward to figure out how to best operationalize it. This is not going to happen overnight for sure, but there's got to be clear commitments that can be done immediately, actually, and not wait another year or two for a committee to go through a process. There are some concrete things that can be done now.
And thank you for saying that, Dr. Simon. So before we wrap up, I'd really like to thank all of you for engaging in this conversation. I am so glad that we were able to have a reasonable conversation on such a sensitive topic. But before we finish, I'd like each of you to perhaps give us one key takeaway or an actionable item that our audience can take back to their home institutions and perhaps start to implement. I know there's a bigger picture, but what can we start implementing now at our home institutions? I'll go around the room. Dr. Kavanaugh?
Sure. Yeah, I thought about this. I was thinking about how to answer the what's your takeaway thing or suggestion. And I guess maybe because I'm a small-minded person, that I look at it at a micro level too. There's a macro thing, so I'm going to make the micro suggestion. And the micro suggestion I'm going to make is just that I think it would be good if all the white radiation oncologists who might be in the audience would actually just on a regular basis look back at their most recent interaction with a person of color, a Black person or other, and identify and think carefully about, would that interaction have been different if the other person was of a different racial background than you? Or I should say, of a different racial background, the same racial background. So, I mean, because there are those famous studies where, looking back, how sometimes Black patients were treated for symptoms. And so in the patient-doctor context, are you treating that patient the same way as you would treat a white patient? In the collegial context, was there something about that? And in the other, in the supermarket, would you treat someone else that? I think there's room for micro reflections on that level as among the many things we can do.
Thank you. Dr. Miller?
I'll speak as an institution for the publishing arm of ASTRO. Not something for us to do at home, but we need leadership that picks the right editors and editors that make the right priorities, and because there is power at the top to influence things. And we have a new generation coming, and hopefully they'll do the right thing when the time comes.
Thank you very much. Dr. Jacobson?
If you're a member of ASTRO and you're listening to this, when you get the notification on November 17th to vote to change our bylaws to create a HEDI council, do that and tell your friends.
Thank you. Dr. Maya-Vega?
Thanks, Dr. Madhu. I think the important thing is, there's survival decrements associated with poor representation. To cite, I guess, data from OB-GYN, there's mortality decrements from Florida data for infants who are Black who are not treated by a Black physician. And so it's very important that we address that. And to echo what Dr. Jacobson said, every ASTRO member can do that. It's as simple as, at your home institution, looking around the room and figuring out who is not represented. Because you don't want to be the people who made the pulse oximeter and realize, oh, this is a great machine, and not realize it doesn't work. It doesn't work well for people who have darker colored skin.
Dr. Chapman?
Sorry. I'm going to speak to resources. I think, right, we live in a capitalist society. Again, some of our ancestors were brought here to be as capital. So we need to redistribute that. That's the only way we're really going to start to make progress. And so I think that people in each of their roles, whether it's the department chair and, right, let's be honest, a lot of our departments in radiation oncology have a lot of resources. So think about how you're, distributing those equitably, and are you supporting populations that have been and continue to be excluded, people who control funds in other ways, whether it's through, writing grants. Think about, giving funded effort to investigators whose expertise you need, right? We're talking about these cancer support grants, and all of these things are important. So really think about what you can do with your resources to be more equitable and address these issues of racism that have plagued our society from day one.
Thank you, Dr. Chapman. Dr. Simon?
Yeah, you got to look at your own backyard first. All right. You got to look in your own institution. I don't care how fancy you think your institution is. Mine is next to Neiman Marcus on the Gold Coast, downtown Chicago. Fancy schmancy. We have number one this, number one that, best at this. That doesn't mean there's inequitable care. That doesn't mean that we haven't looked under the hood of the car and actually looked at the quality data across all our cancer patients and look by race and ethnicity and anything else you want to look at, payer status, etc. There's disparities there. Absolutely inequities. And you got to clean up your own backyard before you can actually participate in the rest of the world and ASTRO, etc. Look at your clinical trials. Who is being actually approached? Don't just look at who gets enrolled. Who's being approached for your clinical trials and who's not and why? those are two important questions that many clinical trials offices aren't actually querying about. And then finally, look at your search committees and admissions processes. Are there board scores that are still, preventing certain people from getting interviews than not? Are there, who's on that search committee for your leadership positions or any faculty position that's the diversity champion? There has got to be strategic intentionality at every single level.
Thank you so much to all of our panelists for those insightful comments. Well, it looks like we've run out of time, but we would like to thank you all for attending this session. This concludes the DEIinRO series for the 2021 calendar year. We're working on session topics for next year's social series, so please stay tuned. If you missed any session this year, you can watch the recordings on our website at astro.org/DEINRO. This year will be a critical year to ensure we have an impact on the development of more of these sessions. So please ensure you're a member in good standing, as we will need many of you to vote starting November 17th, that's in 2 weeks, to December 17th, to ensure the ex officio Council for Health, Equity, Diversity, and Inclusion is voted for in the bylaws revisions to become a fully formed voting member of the ASTRO board. Please check your membership status, be sure to vote, and encourage other members to vote for HEDI as a council. To our panelists, on behalf of Chetty, Dr. DeVille and I thank you so much for your time, for your dedication, and your commitment to change. And to our viewers online, thank you so much for joining. We'll see you next time. Good night.
Thank you.